Hi, my name is Patrick Fay, and for the final discussion of MN 660, I will be discussing the course objectives and how our class met those objectives. And I wanted to thank Dr. Hamilton Smith. I enjoyed this class, and I think we'll benefit and do well from here. Recapping with my agenda is the introduction, and this will be covering course objectives for MN 660, neuroanatomy and psychopharmacology. Um, but the specific course topics that we and objectives we met were related to neuroanatomy, neurophysiology, neurobiology, pathophysiology, evidence-based practice, the psychiatric MP role, and professional collaboration. So for the first objective, we learned a lot about brain anatomy, and it doesn't necessarily have to be trauma as in form of a car accident or um, head trauma, falling down a flight of stairs or something that you'd think of normally. It could be trauma related to a tumor in the pineal gland causing sunset eyes by the pushing on um, different part of the brain, or doesn't have to be trauma at all. It could be from chronic stress associated with changes related to PTSD, um, to the neurobiological function, um, in which there's been increased cognitive decline and development of dementia in patients. Moving on to genetics, we see bipolar has a significant genetic factor, familiar prevalence, specifically with gene variations and mutations. With those bipolar patients, we also see in MRIs or CAT scans a difference in the structural and functional areas of the brain, like the prefrontal cortex and the hippocampus, may be smaller or more affected. Um, Lastly, in some bipolar patients, we see there's imbalances with the neurotransmitters such as serotonin, dopamine, and norepi playing a role in their mood swings. To cover substance abuse and induced disorders, you can also see similarities with bipolar in some patients who use drugs that are illegal. And uh, one of the drugs can, as far as alcohol goes, can cause areas in the brain to be damaged and develop Wernicke syndrome. Um, that in itself can cause encephalopathy and psychosis. Also, confusion, ataxia, ocular abnorma- more abnormalities. Sorry, and with cortical psychosis, we'll see memory impairments, um, hallucinations, and apathy. Throughout this course, we use the DSM-5 and mini mental status exam or mental status exam to assess, diagnose, and manage mental health conditions. With the DSM-5, we used it to provide standard criteria for diagnosing mental health disorders, identifying and classifying these mental health conditions based on specific symptoms and behaviors um, in an accurate fashion. Using it also helped with crucial developing of effective treatment plans and appropriate diagnoses. Uh, Again, with the mental status or mental state exam, it's basically the brief 8-point observational tool that was provided by Dr. Hamilton Smith, um, in which we screen for cognitive impairments and behavioral dysfunctions. It helped us with the diagnosis of symptoms and conditions like anxiety, depression, bipolar, and schizophrenia, among others, providing a quick, reliable measurement um, of cognitive status uh, and aiding us in the detection of mental changes. We should do a mental state exam for every patient, every visit. By integrating these tools, mental health professionals can provide comprehensive care tailored to the needs of individuals, groups, and families across the lifespan. This approach helps obtain accurate diagnoses and gives direction to the treatment plans, such as whether to use SSRI or SNRI for treatment of anxiety or depression. We also learn about postpartum depression in pregnant women or new mothers, which is safer to give something like sertraline that's less likely to cross the placental barrier or into the breast milk. We must remember that the first line treatment for adolescents and children with anxiety and depression is psychotherapy instead of using medications, and that it is essential to rule out changes in altered mental status in populations such as the elderly, um, as far as like making sure it's not related to body functions or decline in body functions versus a psychiatric disorder when they've had no history of mental illness. So that reiterates the fact that depending on our population group and age, will determine how we will um, provide treatment and a care plan. Continuing on with care across the lifespan, it's important to know whether pharmacological, non-pharmacological, or complementary therapeutic interventions are helpful for their psychiatric disorder. One example is bipolar 1 treatment for preventing mania and acute episodes. So the disorder itself comes with um, different treatment plans if depending on whether it's acute or if they're in more of a chronic state. For acute state, you may want to give a immediate antipsychotic, but once they're stabilized, you'll want to move over to mood stabilizers such as lithium or valproate or Tegretol. Um, Antipsychotics such as Seroquel or quintinipine is the alternate name for that. Olanzapine is another one, and Risperidone or Risperdal. Sometimes you'd want to do a combination therapy of mood stabilizers and antipsychotics to bring them back to a stable condition in which you can uh, reiterate and use psychotherapy. CBT will help, and it's seen to have better outcomes with combination with medications and bipolar patients. Lifestyle modifications such as regular sleep and reduced stress and avoiding alcohol or other drugs can help prevent these acute manic episodes and is encouraged. Support systems engaging with groups via networks that can provide emotional stability and encouragement. And then also want to see that we follow up with these patients regularly to make sure they don't need any medication adjustments. Check their labs like creatinine and liver function tests. Moving on to children with anxiety and their treatment with psychotherapy versus psychopharmacology. Treating anxiety in children can involve both psychotherapy and psychopharmacology. The choices between the the differences of severity of the anxiety, the child's needs, and family preferences. Um, Again, with children and adolescents, we want to make sure we lean more towards cognitive behavioral therapies or any of the other psychotherapies that are relevant to anxiety. and helping the children learn to manage their anxiety through thought patterns and behaviors, um, gradually facing their fears and getting control of their anxiety in a supportive environment. This benefits the children by providing long term coping skills. Uh, they don't have to worry about the medication side effects. It can be tailored to the child. Um, some of the drawbacks are that it requires regular sessions and progress can be kind of slow. It's more difficult for the family to like um, invest the time in traveling, the money in gas, just making it to appointments. But it still is priority to um, emphasize the importance of it versus psychopharmacology. Medications that you could give the child are still the SSRIs, commonly prescribed for children with anxiety. These medications reduce the symptoms and balance the neurotransmitters of serotonin, as we talked about and learned. Can provide a quick relief of symptoms and are useful in severe anxiety. Drawbacks are potential side effects include nausea, headaches, sleep disturbances. Sometimes um, requires careful monitoring for things such as how it may affect someone's heart uh, and electrical functioning of the heart. Um, but the drawback is that it doesn't teach coping skills, so it should really be combined with therapy. One of the final topics I chose to discuss for this slide is disruptive mood dysregulation disorder. In children, typically it can be treated with combination of psychotherapy and medication, just like anxiety. We would look at CBT therapy, uh, training the parents to respond to the children's or child's irritability and temper outburst in a way that improves the children's behavior. Um, so we might prescribe some family therapy with a licensed professional counselor. Lastly, we could also consider medications such as stimulants that you might see in ADHD or antidepressants such as SSRIs to help manage some of their mood symptoms. In worst cases, maybe a typical antipsychotic like Risperdal um, or um, Haldol to reduce severe irritability and aggression. Again, just like anxiety in children, we would see that most likely it's recommended that they get some sort of psychotherapy and medication, but I would lean more towards um, psychotherapy and seeing how that pans out first. Despite acute, chronic, or complex mental health, it is our duty to ensure safe and effective treatment for all the patients in mental health because they deserve the same quality and rights, such as being able to give informed consent, autonomy, non-maleficence, beneficence, and justice whenever possible. There's going to be some situations in which the patient is incoherent or um, incapable, but we should still educate the patient on the benefits, risk, and alternatives to treatment. Um, we should try to teach them on their level in which they can understand things like potential side effects or long-term impacts of medications while letting them make the most decisions on their own behalf as possible, um, but preventing harm or self-harm is important to promote their well-being and ensure adequate treatment despite the potential of disability, and to have fair access to treatment and resources is key.